Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Hey guys, thanks for being listeners of the show. Go to dentalimplantpractices.com and find all of our resources. Also find us on Facebook, Dental Implant Practices page on Facebook, and go to iTunes and leave me a review on iTunes so we can help spread the message. Thanks.
Hey everybody, welcome back to the Dental Implant Practices podcast. I'm your host, Philip Gordon. Today, what I want to talk about is treatment planning and diagnosis and figuring out just how and where to place those darn dental implants. So there's many things to consider when looking at dental implants, and we're going to cover what it is you want to look out for and what you need to be thinking about when you're diagnosing and treatment planning for a dental implant. When patients come in either desiring for an implant or we determine that a dental implant is necessary, we obviously want to figure out the chief complaint and the goals for the treatment, whether it's replacing one tooth or multiple teeth or fixing a hole in the smile, what it is that's really driving the patient. So that's always something to take into consideration. Next, we always want to get a current health history and medication list. So obviously the health history is important legally, but there's also things we want to look out for. Is the patient a smoker? Are diabetic problems a concern? Is the patient taking any bisphosphonates or have in the past? Are there any blood thinners that need to be considered and kind of sidestepped or navigated? Or are there any other high blood pressure or medical risks, that need to be evaluated? So a current or previous medication list. The other thing that's important with that might be allergies. So when considering which type of anesthetic to use or latex, what kind of medications or pain medications or antibiotic use might be, indicated. We want to know those things ahead of time. And then there also needs to be some thoughts about, what type of imaging are we going to be needing for this patient. Obviously, a full mouth series, including bite wings and periapicals of the implant area, a panoramic radiograph and or a 3D cone beam, a CBCT of the patient is preferable, not always mandatory, depending on the school of thought or who you talk to, but definitely if that's something you can obtain, then that's always going to help in multiple aspects that we'll talk about moving forward. Also good to have a periodontal charting of the status of the mouth and evaluation of the TMJ, occlusion, what type of gingival biotypes are we dealing with? How much keratinized tissue and attached tissue is there for stability? And then, do we take any intraoral or extraoral photographs for diagnosing clinical case coverages or documentation or just, communication with the lab? So those are all reasons to take dental photographs of many kinds. Obviously, once a treatment plan has been built and accepted, that's when, I would recommend getting impressions, usually wanting a upper and lower full arch with bite registration. A lot of times a face bow may be necessary if we are working with a complex case, or if it's a single case, sometimes just the upper and lower impressions and a bite registration really is all that's necessary. Always a good time to get a tooth shade of the area too, in case there's going to be a temporary made or a flipper or a bonded restoration like a Maryland bridge, that may be needed. And any other referrals, slips, or communication if you're dealing with a specialist, whether it be you're placing the implant or a specialist is placing the implant, or there, maybe a sedation expert coming in to help with a case. And that usually is a good start for diagnostic data to get. When considering the dental and medical history, there's obviously some risk factors, and people always ask, when will you do, when will you place implants? When won't you place implants? What are the biggest risks? And really, I think it's a case by case, patient to patient. Are they willing to take a chance? Am I willing to take a chance? case-by-case ordeal. I don't know if there's a hard line in the sand on what I will and won't treat, but that's probably comes with a little bit of experience, and you kind of have to determine your own things. But obviously risk factors are age. We don't want to place a lot of implants on anyone who may not have full skeletal growth, so maybe under 18 on females or 21 or 22 on males. That's a pretty conservative range where skeletal growth plates have typically closed. You also want to look at very old, how brittle is the patient's bones, if they're extremely old and have had bone problems. You want to look at how healthy are their bones, how brittle are their bones, or are they osteoporosis or osteopenic, and do they have good bone health? And obviously the bisphosphonate question, have they taken any in the past or plan on taking any bisphosphonates in the future? The other considerations that we may want to be looking at would be compromised medical condition or psychiatric conditions. Obviously medical or psychiatric unstable people may not be the best to enter a implant project with, as these generally last months or a year, and there can be maybe bigger conditions that need to be addressed earlier. So may want to think about those. Other risk factors are high aesthetic demands. If this is your first implant, placing one in the number 8 or 9 in the smile zone with a high reveal of the lip is probably a high risk factor for you. So where is the implant, and how are we going to restore this, and how are we going to place it? And your experience in moving bone and gum tissue obviously is a big consideration. The availability of the patients to come to see you are obviously something to consider also. We don't necessarily want to start treatment with people that will be moving or can't make it back for maintenance and recall appointments, as there's generally quite a bit of follow-up appointments that may be necessary. Other factors to consider might be the patient's alcohol use or smoking. The alcohol use could decrease their ability to heal and increase their bleeding problems. And the smoking is heavy smoking, I feel, may be a contraindication, but mild or moderate smoking generally is not a X factor for me, but definitely is one thing to look at. If they have multiple strikes, that may be a no-go case for you. But if that's the only strike and an otherwise pretty healthy patient, that may be a workable scenario. So periodontal disease, much like smoking, is not a major red flag for me, but definitely we want to try to treat the periodontal disease and get it under control, do some systemic and oral antibiotics, and get things stable so that doesn't affect the healing of the implants, as that could be a problem there. Range of opening for the jaw might be a problem if the patient can't open enough to get instrumentation into the mouth. And that may sound silly, but dental implant drills are usually very long, and patients do have to open pretty wide for these procedures for a long time. So they're definitely want to check that, as I run into that problem a time or two myself. Other problems to consider with risk factors could be, vertical bone height, horizontal bone height. Are the teeth mesial and distal to the restoration? Have they tipped in and blocked out our restorative space? Is there enough space between the adjacent arch when the patient closure? Do we have enough height to restore with the tooth? Are there any other lesions of the jaw or bone or gum tissue that maybe need to be dealt with first, or other acute problems? So always things to consider. Once again, as it relates to the aesthetic factors, we just want to look at the high gingival line, the thin buccal bone. If there's not a lot of buccal plate, there may be some bone resorption there, and subsequently gingival resorption. The papilla and thickness of the surrounding gingiva are important, as we don't want a thin biotype for that, as that could show through the bone or the metal or the subsequent restorations that may be going on it. Those are things to look at. Those might be scenarios where more involved specialists or, bone grafting or gum tissue grafting before surgery may want to be evaluated, or, the hygiene level of the patient. Do we need to stabilize a gingivitis or a periodontitis level beforehand? So other risk factors that may look at might be more in the functional occlusion category. The functional bruxism risk, the clenching, grinding, thrusting, these are forces of occlusion that cannot be underestimated, and definitely needs to be considered if a immediate temporary is going to be planned, as patients will grind and brux regardless of the type of night appliance used. When evaluating a patient for the placement of a dental implant in the mandible, when looking at a CBCT scan or a panoramic, what we want to do is locate the inferior alveolar nerve, the direction and the path and the exit of that nerve through the mental foramen. And any implant we place, it's recommended to be at a minimum of 2 millimeters above or away from this nerve at all locations. So the inferior alveolar nerve and mental foramen, actually it's recommended about 4 millimeters from the mental foramen itself. Those are things we want to watch for, as the mental nerve loop can be a little larger in some. The mandibular incisive canal can also be something to look for. Those are two main nerve pathways to check for. Also want to look for potential undercuts, being the submandibular fossa, and the overall position of the mandible as it leans inward. We want to watch the angle of the implant, as the implant cannot go through the buccal or lingual wall. We want to watch the angle as it relates to those various undercuts that the mandible has. We want to look at the crestal ridge. Is it regular, or is it knife shape, or is it U-shaped? Are there any other anatomical variances in the alveolar ridge where the implants can be placed? Obviously, we want to look at the position as it relates to the adjacent teeth. If we are placing implants next to adjacent teeth, we want to look at a minimum distance from the implant to the teeth being 1.5 millimeters, and a minimum distance from a implant to implant placement being 3 millimeters. So those are important numbers to always keep in mind. When looking in the maxilla, the upper arch, there are obviously certain different anatomical evaluators and things to avoid. So we want to take a look at the shape of the vault of the upper arch and figure out any undercuts that may be in the upper jaw. We obviously need to look out for major landmine or thing to avoid in the posterior maxilla, being the maxillary sinuses. Typically those will start around the second premolar and move all the way to the back. So depending how long teeth have been out, or depending on the patient, those sinus floors may dip down substantially and cause a severely shortened height of bone to place our implants. So that's where the CBCT really comes in handy. If we can treatment plan from that, we're at a much better spot. If not, we're relying on purely the two-dimensional radiograph, which sometimes can be misleading for that. Any other pathologies that may exist in the sinus. So definitely a little harder to read the upper jaw without a CT scan, but can be done, but definitely things to look out for. Those are definitely some of the major things to consider. That list seems rather daunting, but once you get comfortable evaluating patients and running them through your treatment planning process, those seem relatively routine. What I, myself, and a lot of other practitioners like to do is potentially use checklists for these types of things. Checklists can be good for assistance when determining which x-rays and models and bite records need to be taken, but also keep the doctor and team on point and on check when looking and diagnosing, so that nothing gets overlooked. For single implant cases or multiple implant cases, there may need to be different checklists and different things. So always understanding what the goals of the case are before starting records and diagnosis is important. Are we planning no temporization? Are we planning immediate temporization? Is this going to be a single stage surgery, or is this going to be a traditional model where the implant is buried and then recovered and have a healing abutment placed and then take impressions and a final crown placed? Is an extraction and immediate implant placed? Obviously, these all have different criterias and different things needed from a laboratory standpoint and a provider time standpoint and a monetary standpoint on the patient side too. So these are all thinking with the end in mind, and then working our way back is a great way to treatment plan some of these cases so that nothing gets skipped. And obviously a complex full arch implant case takes a lot of time in planning and records and multiple stages and many communications between various specialists and labs. So the more extensive the case, the more detailed an analysis and record taking that needs to be considered. So having good communication with your lab ahead of time before these cases start is always a good idea. So finding a lab that works with implants or that specializes in fixed or removable implant placement is always a good idea. And having those details worked out before the case is committed is always a good idea. And then if there is a case presentation for the patient, having the full treatment plan from start to finish presented ahead of time will always save trouble, so that things like temporary crowns or temporary splints and surgical guides and bone grafting and impression copings and all these extra services that go into implant dentistry can be accounted for both financially and potentially waived off on the patient. Yes, they want a temporary. No, they don't. Yes, they're willing to pay for it. No, they aren't. Understanding why this surgical guide may be necessary and why it's the patient's best interest to pay for it. Are they going to a scanning center? Are all the x-rays going to be taken in-house? Is there sedation involved? Is there not? So these are all things that can really increase or decrease the time and money involved with each of the treatment, and definitely need to be presented ahead of time before the case is even accepted. In addition to all the fees and possible turns that the case may take, we also want to acquire the proper consents, breakdown of fees, present the financial options. Are they going to pay for it all at once? Treatment plan? Are they going to do care credit? Are they going to have insurance? But then also the informed consent for the patient's sake and your own, covering all the risks involved and potential outcomes. Definitely something you want to have before treatment starts. And then anything that, relies to sedation or having the patient understand what is expected of them at each appointment is always good to, definitely run through ahead of time so that everyone feels like they're on the same page before we start and nothing needs to be explained later, as consents and financials explained after the case starts are much harder to overcome or objectives than before the case starts. So definitely wanting to emphasize the importance of those, as I have learned that the hard way a time or two. So these are some of the basics in understanding your kind of treatment planning and diagnosis. Obviously, we may dive in deeper on each one of those topics at some point, but that's a good overview to start treatment planning, whether or not you are placing the implants or using a specialist referral. Either way, thinking through your steps and covering all your bases before any treatment is started is always a good way to have everyone on board for a successful outcome. So this has concluded our episode for today. So look forward to seeing you guys next time, and go drill some bone.